This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub Podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Elara. Today we're looking at a fascinating new study from the journal Child's Nervous System, published in 2026. The paper is titled, "What is the Best Surgical Approach for Pineal Region Tumors? A Systematic Literature Review and Anatomical Comparative Study."
This is a topic that is near and dear to every neurosurgeon's heart, and perhaps a few of our nightmares. The pineal region is famously difficult real estate because it's situated right at the juncture of the midbrain and thalamus. It's deep, it's central, and it's surrounded by some of the most critical neurovascular structures in the human body.
Exactly, Dr. Aris. And what makes this paper so interesting is that it doesn't just look at the literature. It combines a massive systematic review of over 1,700 patients with a hands-on anatomical dissection and tumor simulation study. They really wanted to settle the debate between the two heavyweights, the supracerebellar infratentorial approach, or SCIT, and the occipital interhemispheric transtentorial approach, OITA.
It's a classic debate. When I was a resident, it felt like every attending had a favorite approach, based more on habit than high-level evidence. What did the systematic review show regarding which approach is actually being used in the modern era?
The authors looked at 27 studies involving 1,774 patients. It turns out the split is quite narrow, but OITA actually took the lead at 42.21% of cases, with SCIT following closely at 38.27%. This shows that while SCIT is often taught as the workhorse for the pineal region, OITA remains a very dominant force in clinical practice.
That is a significant sample size. Now, for the residents listening, the most important part of choosing an approach isn't just getting there, it's what happens to the patient afterward. What did the study find regarding the complication profiles for SCIT versus OITA?
This was one of the most robust parts of the paper. They found statistically significant differences. The SCIT approach was more commonly associated with cerebellar complications, which makes sense given the retraction, as well as CSF leaks, meningitis, and Paranod syndrome. In fact, for those specific complications, the p-value was less than 0.005.
Interesting. Paranod syndrome, paralysis of upward gaze, is often thought of as a symptom of the tumor itself pressing on the tectal plate, but this suggests the SCIT corridor itself might carry a higher risk of exacerbating or causing it during the manipulation of the infratentorial space. What about OITA?
OITA had its own specific trade-off. It was associated with a higher incidence of homonymous hemianopia, with a p-value of 0.0011. This is the classic risk of retracting the occipital lobe to get that interhemispheric access. So the choice really becomes a balance between risking the patient's visual fields with OITA versus risking cerebellar function or ocular motility with SCIT.
That's a crucial clinical takeaway. Now, the paper didn't stop at the literature review. They performed anatomical dissections to quantify the exposure patterns. How did they break down the pineal region into quadrants for this study?
They divided the pineal region into 4 quadrants. Q1 and Q2 are the inferior quadrants, while Q3 and Q4 are the superior quadrants. Through their anatomical work, they confirmed that the infratentorial approaches, the standard SCIT, provided the broadest exposure of those inferior quadrants, Q1 and Q2. However, they found that OITA offered significantly greater visualization of the superior ipsilateral quadrant, which they labeled Q3.
So, if your tumor is pushing superiorly, OITA gives you the direct line of sight. But I noticed the paper mentions a third option of sorts, the SCIT with a tentorial incision, or SCIT plus T. What did the anatomical simulation show for that?
That was a bit of a game changer in their results. They found that adding a tentorial incision to the SCIT facilitated visualization of the supratentorial quadrants, Q3 and Q4, which are otherwise almost inaccessible through a standard infratentorial corridor. It basically expands the versatility of the SCIT, allowing it to compete with the OITA for those higher-reaching lesions.
Let's dive deeper into the tumor simulation. This is where the authors tried to move beyond which approach is better and towards which approach is better for this specific patient. They focused heavily on the deep venous system, didn't they?
They did. The study emphasizes that the relationship between the tumor and the deep venous system, specifically the galenic system, is perhaps the most critical factor in approach selection. According to their simulations, supratentorial routes like OITA favor lesions that are anterior to the veins. Conversely, infratentorial corridors like SCIT favor tumors with posterior extension.
That's a fundamental rule of thumb. You never want to be working through the deep veins if you can avoid it. You want the veins to be shifted away from your primary corridor. If the tumor is above the veins, you come from above. If it's below, you come from below. But what about the tentorium itself?
I've always found that the slope of the tentorium dictates my comfort level with SCIT.
The paper agrees with you, Dr. Aris. They noted that the selection between SCIT and OITA should be individualized based on tentorial anatomy. In cases with a steep tentorium, the OITA, initially described by Poppin and refined by Jameson, provides excellent lateral exposure. However, if you are committed to an infratentorial route in a patient with a steep tentorium, the SCIT plus T, the tentorial incision, becomes almost necessary to see the superior poles of the tumor.
Let's talk about the surgical real estate for a second. We've discussed the visual field risks of OITA and the cerebellar risks of SCIT. For our trainees, how do we decide which risk is more acceptable?
The author suggests that the complication profile should be weighed against the tumor's exact coordinates. If you have a tumor that is primarily located in the inferior quadrants but has a small superior extension, you might start with an SCIT but be prepared to incise the tentorium. If the tumor is purely supratentorial or anterior to the vein of Galen, the risk of homonymous hemianopia in OITA might be a necessary trade-off for the safety of the deep veins.
It's also worth noting the meningitis and CSF leak finding for SCIT. Why do you think the study found a higher rate there?
The paper suggests it's likely due to the proximity of the cystins and the nature of the infratentorial closure. SCIT often involves a wider opening of the arachnoid in the supracerebellar space, and if the closure isn't watertight, the gravity-dependent nature of the posterior fossa can lead to those complications.
Very true. Now, looking at the conclusions of the paper, they state there is still no single best approach, but they provide a framework. How would you summarize their final recommendations for a surgeon planning a case tomorrow?
I think the take-home is threefold. First, the choice between SCIT and OITA must be individualized based on the tumor's relationship to the deep venous system, posterior versus anterior extension. Second, look at the tentorial anatomy. A steep tentorium may push you toward OITA or require a tentorial incision if you go SCIT. And third, be mindful of the specific morbidity of each approach, visual fields for OITA, and cerebellar, ocular motility, CSF issues for SCIT.
And don't forget the SCIT plus T. That was a major point in their anatomical study. It suggests that we shouldn't view SCIT as a low-only approach. If we are comfortable with a tentorial incision, we can reach those superior quadrants without switching to an interhemispheric supratentorial route.
Exactly. The paper really highlights that the tentorial incision can expand the versatility of the SCIT in selected cases. It gives us a bit more flexibility in the OR.
This is a great reminder that neurosurgery is as much about geometry and anatomy as it is about technique. You have to pick the right window before you ever pick up the bipolar.
Definitely. And for our listeners, the paper provides some excellent tumor simulation images that really show how the visibility of those four quadrants changes as you switch between corridors. It's well worth a look in the full text of Child's nervous system.
Well, that's all the time we have for today. This has been a deep dive into the pineal region, pun intended. Thank you, Dr. Elara.
Thank you, Dr. Aris.
To our listeners, stay curious, keep reading, and we'll see you next time on the Neurosurgery Hub Podcast.